Good morning, everyone. So in this session, we have two speakers, and the main topic is ovarian stimulation for poor responder and exploring the cause of premature ovarian insufficiency or failure. Our first speaker will be Dr. Alexander Quaas. He is founding partner at Shadicrow Fertility in San Diego, California. He has trained and worked in multiple locations and settings of the medical school in England, residency at Harvard, and reproductive endocrinology and infertility fellowship at USC, and if I remember correct, it was under Richard Paulson, yes. Right? And he completed his master program in clinical and translational science and the ASRM Quest Scholarship while on faculty at the University of Oklahoma. From 2021 to 2023, he was division director of the Department of Obstetrics and Gynecology at the University of Basel in Switzerland. As current president, and congratulations on this, Alex, of the Pacific Coast Reproductive Society, he is very active in teaching and research in the field of REI, and his areas of special interest includes international differences in the provision of fertility care and the use of artificial intelligence in assisted reproductive technology. Please, Dr. Quaas, welcome.
I can say danke sehr. Thank you very much. So yeah, I went to the gym for a little bit this morning to refresh myself before this lecture, and they had the Titanic movie on, and I was thinking, thank God we made it back safely on that boat last night. We didn't hit an iceberg. So let me see if I can advance the slides. There you go. These are my disclosures. Oh. So I actually co-authored a review article on the role of growth hormone in assisted reproduction. And I think that the introduction to this article, to this review article that you can find online, is quite a good introduction to this talk. So in contemporary ART, the use of add-ons, this by itself, the use of add-ons during ovarian stimulation has increased, especially in poor responders. So there was a whole views and reviews section in Fertility and Sterility about this topic. And growth hormone is one of these add-ons, and it's an adjunctive therapy that has been studied extensively in the basic science or translational setting, but also in the clinical setting, with an ongoing debate whether it's actually effective and how it should be used. And so, as a clinician, I'm very interested in which patients should have this. And so the review is more or less the topic of this lecture, which is what is the basic science evidence for the use of growth hormone and what is the clinical evidence. So the biologic plausibility or the basic science evidence for this is that there are receptors for growth hormone in the follicles, but also in the endometrium. So growth hormone has an intermediary hormone called IGF-1 that promotes granulosa cell health and proliferation. And there was growth hormone receptor expression demonstrated in human granulosa cells. That was demonstrated. There was also expression of growth hormone mRNA in goat granulosa cells from large antral follicles, but not the pre-antral follicles. And there was also immunoreactivity for the growth hormone receptor, as you can see in that little picture there. So it was previously known that IGF-1 increases FSH action to increase granulosa cell estradiol secretion. And it has been shown in humans that the growth hormone receptor density increases within age in normal patients, or like normal ovarian reserve patients, but not in poor responders where the growth hormone receptor density was lower. It was also shown that growth hormone treatment increased the density of certain receptors, such as growth hormone, FSH receptor, LH, and BMPR1B. And so this is the sort of translational or basic science evidence that there is for the use of growth hormone. In the review article that I co-authored, you can also see that there was an increased expression of genes associated with meiotic progression and embryo development in human oocytes that were cultured with growth hormone. So in the sort of actually in vitro setting, it appeared to make a difference. Now, it's also been hypothesized, and there's another review article in the same journal by Agajanova et al. That shows certain mechanisms by which growth hormone might actually enhance follicular function, but also endometrial receptivity. Now, what's the clinical evidence? And this is sort of what I'm most interested in as a clinician. So, as early as 2005, there was a randomized controlled trial that demonstrated in 100 patients over 40 randomized to growth hormone co-treatments versus placebo that there was actually a similar number of oocytes and embryos generated in both groups. However, in this article by Tesarik et al., the peak estradiol level, the follicular fluid estradiol level, and the follicular fluid growth hormone level were all higher in the growth hormone compared to the placebo group. And most importantly, the clinical pregnancy rate and the live birth rate were higher in the growth hormone supplemented group. Now, I can't go into every single randomized controlled trial on this topic because there were many of them. But what I can go into is the meta-analysis on this topic, and there were 3. So the first one in 2009 included 6 randomized controlled trials, so for a total N of 169 by Kolibianakis et al. And in that trial, I'll show you the evidence in a moment, superior outcomes were noted. There was another meta-analysis 8 years later by Lee et al., and that one included 11 randomized controlled trials for a total of 565. And that was actually also, it also had a live birth rate outcome. I want to show you the results of these. So in 2009, the Kolibianakis meta-analysis of the RCTs that they included, the 6 RCTs, showed a decreased rate of cycle cancellation in the patients that were randomized to growth hormone. It also showed an increased live birth rate, but the sample size was low. So in 2017, Lee repeated a meta-analysis, and they basically included 11 randomized controlled trials. And what they found is an increased clinical pregnancy rate, an increased live birth rate, decreased cycle cancellation, also a decreased use in gonadotropins, increased estradiol level on the day of trigger, and an increased number of mature oocytes. However, 3 years later, Cozzolino et al. Repeated another meta-analysis, and in that one, there was a total of 12 randomized controlled trial, and what they found is they found an increased clinical pregnancy rate, but not an increased live birth rate. And they sort of said, let's put the foot on the brake of using growth hormone in these patients, in poor responders, because the evidence doesn't really show increased live birth rates. So the conclusions, if you use all this body of evidence, is that in poor responders undergoing IVF, growth hormone probably increases clinical pregnancy rates based on the available evidence, but it's questionable whether it actually increases live birth rates. One of the problems that I didn't go into in great detail is that, number one, the patient population used in all the different studies is quite heterogeneous. And then also the protocol used is heterogeneous because, you know, like people have all sorts of protocols, mostly during ovarian stimulation, but there are also protocols that are used where the growth hormone is used at a lower dose to prime the patient before ovarian stimulation. It appears relatively certain that it may decrease cycle cancellation in poor responders. And so I worked with David Meldrum at Reproductive Partners UCSD, and we wrote this article that stated that in our most difficult patients and basically the poor responders, why are we not using it more? Well, there's an easy answer to it, because it costs a lot of money. And so the question is it cost effective? If you ask Dr. Meldrum, who I co-authored this commentary with, he says absolutely, it's cost effective, but I think this is controversial because it does add quite a bit of money and often out of pocket to the cycle for these poor responders. So there's more research needed. Now, at Reproductive Partners and UCSD, we had this, you could call it kitchen sink protocol or poor responder protocol, where we used all the different add-ons that there was evidence for. So there is actually relatively decent evidence on the use of androgens in poor responders. So we would use, depending on, we had this like mid-luteal esterase antagonist protocol, we had a long esterase protocol, and they had varying durations of testosterone supplementation before the stimulation, and then using growth hormone on day 1 of stimulation. So that was our protocol, 2.9 milligrams sub-Q. We talked about this at the roundtable yesterday. That's half a vial, and it corresponds to about 8.5 units, actually. So this was our protocol that we would use for poor responders, and we would use it quite liberally, but it's very controversial because if you look at the views and reviews section that was published in Fertility and Sterility a while back, the titles already say what the people who put together this views and reviews section believe about this. Is like, can we be honest here? Like, can we actually state that this adds a cost for the patients, and that maybe the evidence for these add-ons and adjuvants and adjuncts is not as clear-cut as some may lead the patient to believe? And do these a la carte menus actually serve infertility patients? And what are the ethics and the regulation of these add-ons? Because we're, sometimes using these add-ons as if there was like clear evidence for their use, when really the evidence is mixed, as I will show you. So what they did in this review that was about 5 years ago is they used a sort of traffic light system for the add-ons, for all the different add-ons that they reviewed for these adjunct medications, including growth hormone. And so green was supposed to be a medication or some sort of add-on where there's high quality evidence to support its use. And then orange was a small body of evidence or conflicting evidence, which means future research or further research is required, and the technique is not currently recommended for routine use. And then red is there's no evidence to show it is effective and safe. And interestingly, in this article, they actually didn't find a single add-on that got the green label for to completely support its use based on available evidence. And the best that these add-ons got was an orange. And so growth hormone was one of the orange ones. And you see the red ones, such as antioxidants, heparin, aspirin, and seminal plasma. Interestingly, platelet, I got a lot of questions yesterday at the roundtable about PRP. I feel like PRP should be red, actually. I don't think it actually really works. There's some practices in town that, call it ovarian rejuvenation, which I think my personal opinion is you can use these add-ons and you can tell patients, look, there is some evidence to support the use. We don't know if it's going to help you. These are the pros and cons. These are the risks, benefits, and alternatives, but please don't call it ovarian rejuvenation. So the take-home points are adjuvants are a potential powerful tool to increase success in IVF in poor responders. And in poor responders undergoing IVF, based on the available meta-analysis and the body of evidence, growth hormone may increase clinical pregnancy rates. We don't know really if it does increase live birth rates. It may. It seems to, for sure, decrease cycle cancellation. And this is actually a little bit similar to PRP. We're actually just in the process of submitting a meta-analysis on the use of PRP for publication. And it really does appear to increase ovarian reserve markers. So it might increase the antral follicle count. It might increase the AMH level. But that doesn't always necessarily translate into an increase in live birth rates. So according to the meta-analysis that we stated in our commentary together with David Meldrum, it did appear that maybe a number needed to treat of 7.6 was cost effective, but that was based on the 2017 meta-analysis, not the 2020 meta-analysis. So, as we always say, more research is needed to analyze the role of growth hormone in poor responders. All right, I think that was more or less the time. And if anybody has questions, feel free to bring them up now or later. Happy to take questions.